Hi, and welcome to the webinar Treating Eccentric Calcium, Addressing the Thorn in Your Side. I'm Margaret McIntyre from the Golden Jubilee Hospital in Glasgow. I'd like to welcome my co-hosts, Professor Carlo Di Mario and Professor Holger Neff. Welcome.
Hello.
Thank you, Margaret. Thank you for having us here.
So we're going to start the webinar with myself presenting some background on the assessment and management of calcium. We'll show you a live in a box case, and then we're going to see some really interesting data from both Holger and Carlo. So we'll get started. And I'm going to start the session with some background of everyday problems we encounter in the cath lab in dealing with calcium. So we know that the presence of severe coronary calcium impacts on long-term PCI outcomes. There's now data from meta-analysis of multiple studies, both in stable and acute patients, showing that severe calcium is associated with increased long-term death, cardiac death, and MI. Thinking specifically about the left main, which will be relevant to the case we're going to discuss later on, this is a sub-study from the EXCEL trial published last year, which showed that the presence of moderate or severe calcium in the left main was associated with increased 3-year death rates. And when we looked at the outcomes in patients who were either treated with PCI or bypass, there was no difference. So calcium was equally impactful in with both treatment options. When we think about how best to assess calcium, it's important for us to realise the limitations of coronary angiography. So this is a study of 440 patients who all had CT-CA that showed the presence of coronary calcium. They all then went on to have angiography, OCT and IVUS performed. And what they found was that only 44% of the patients had calcium detectable in the angiogram, even though it had been seen on the CT. This was increased to 77% when OCT was done and 83% when IVUS was done. Somewhat reassuringly though, if the operator felt that angiographically there was either no or only mild calcium by the MINT's definition, when they went on and looked at the OCT, they found that the calcium that was detectable was indeed mild. So the arcs of calcium, the thickness of calcium and the length of calcium was all quite reassuring. If though angiographically you feel there's moderate or severe calcium, so multiple radiopacities, calcium on both sides of the vessel, then you really need to go on and perform intravascular imaging to further assess the calcium and determine how best to modify that. Because they went on to look at the OCT and found that in this patient group, the arcs, the thickness and the length were significantly larger. When we use IVUS to assess calcium, there's a number of things we're going to look at. So we're going to look to see this white hyperechoic leading edge that's classic of calcium on IVUS. You're able to measure the size of the arc of calcium. You can determine whether it's concentric or eccentric. You can look and see whether the surface is smooth or irregular, like in the picture in the top right-hand corner compared to the central picture. And that can give us some indication of thinness or thickness, so smooth, white, echoic surface usually is consistent in OCT with thin calcium, whereas a kind of craggy, irregular surface is more associated with thick calcium if measured in OCT. We can also look for these reverberations shown by the arrows in the central picture, which are like echoes, echo signals behind the surface calcium. This also is an indication that the calcium is likely to be thinner rather than thicker. In the longitudinal view, we can measure the length of the calcified segment, and we can look for the presence of calcified nodules. So as you see down there in the bottom right-hand corner, you see a protrusion of tissue into the lumen with a bright, craggy leading edge. Similarly, on OCT, we can measure the arc, we can look at the length, but particularly in OCT, because we can see both sides of the calcium, we can usually also measure the thickness of the calcium, which can't be done specifically on IVUS. We can obviously also, just like an IVUS, see nodular calcium as you see in the top right-hand corner. We've known for a long time that the size of the arc of calcium predicts stent under expansion, and that stent under expansion is a predictor of long-term clinical events. More recently, Fujino and the Japanese group did a multivariate analysis looking at predictors in OCT of stent expansion. And what they were able to show was the strongest predictor, indeed, was the arc of calcium if it was more than 180 degrees. But they also showed that thickness and length of calcium was also predictive of stent expansion. And as your score of all these things increases, the stent expansion decreases. Last year at TCT, the same expanded group also looked at a potential IVUS calcium score to predict stent expansion. What they did on this occasion was all the lesions had at least 270 degrees of calcium, so all the calcium was concentric. And they then went on to look at other independent predictors of stent expansion. And they showed again that the length of the calcified segment, they showed that if the vessel was relatively small, so less than or equal to 3.5 millimeters, or indeed if there was a presence of a calcified nodule, that all these other things were independent predictors of stent expansion. And as those factors accumulate, your stent expansion goes down. In 2018, the European Society produced a guideline of what you should look for to optimize your stent post-PCI. And importantly, in the context of calcium, they recommended that your stent expansion should be over 80%. And this is measured by measuring your minimal stent area and then getting the mean of your reference lumen diameters at the proximal and distal end of your stent. And that should be over 80%. They also went on to look at eccentricity and recommended that you want an eccentricity index of greater than or equal to 0.7, and that's calculated by taking your minimum lumen diameter and dividing it by your maximum lumen diameter. The other thing that's important to consider is stent asymmetry, and we know from some work by Chambers that we can see some asymmetrical stent expansion in up to 50% of lesions which are calcified. And you often get this D-shaped appearance you see here with some protrusion of a mild nodule in the upper quadrant of that stent. This is both eccentricity and asymmetry are important. Some data from the Absorb IVUS sub-study showed that these two things together are associated with long-term device-orientated clinical endpoints. So having an asymmetric or eccentric stent seems to correlate with poorer long-term stent outcomes. In terms of how we go on and deal with the calcium, we now have an array of options. We have multiple balloon-based technologies with the recent addition of intravascular lithotripsy, shockwave. We obviously have the available atherectomy devices. In terms of which device we choose to use, there are multiple factors involved. One way to think about this is to think about the morphology of the calcium and use that to try and help us select which treatment we think is going to be most appropriate. So if we think about calcium in terms of eccentric or concentric, if we define concentric as calcium of more than 270 degrees, that can either be thin or thick. If we think about eccentric calcium, it can be very mild calcium, maybe just an arc of 90 degrees, like in the top IVUS image you see there, or it can be slightly more significant, maybe about 180 degrees in the second image, but thin. We then have the issue of whether the calcium arc is relatively small, but the calcium is thick. And then we also have this issue of nodular calcium. So how do we decide how best to select the most appropriate device in these different anatomical features of calcium that we see every day in the cath lab? If we start with looking at concentric calcium, if you've got more than 270 degrees of calcium, but the calcium is thin and the segment is very short, so less than 5 millimeters, maybe 3-4 millimeters in length, you may well manage to modify that calcium with a modifying balloon, such as a scoring balloon, cutting balloon, or even a high pressure balloon. But as these features increase, so as the arc gets bigger, the calcium gets thicker, and the segment gets longer, you're going to have to think about a more robust modification device. And in the kind of the thinner end of the spectrum, you may think to use atherectomy, but as that calcium gets thicker, it seems that shockwave is going to be more effective because it has this ability to create microfractures deep into the vessel wall through the intima and the media. If we look at eccentric calcium, at the less severe end of the spectrum, again, the modifying balloons are likely to be adequate to deal with this, but as the eccentric calcium becomes thicker, the arc becomes bigger, or we're having to deal with nodular calcium, then typically and traditionally we would at this point usually choose to use an atherectomy device, such as rotational atherectomy. In terms of why we've made those choices in the past, why we've chosen to use atherectomy for eccentric calcium, it's based, I suppose, on the theory of how IVL works optimally. So this idea that the shockwave balloon emits high frequency waves, these waves are reflected off calcium. The reverberate increases the effectiveness of the therapy. So the more concentric the calcium is in the vessel wall, the more effective the device works, and the more fractures you're likely to produce. But as we've been using the device more in clinical practice over the last couple of years, certainly in the hands of high volume users, there is an impression and an opinion that actually IVL is very effective also in eccentric calcium as well as concentric calcium. And that's what we're going to discuss at some length today. So if we come back to this kind of mini algorithm, I suppose, the question I think that's really up for discussion is, do we think that shockwave is effective and has a place in the treatment of this proportion of the patients that previously have been managed more traditionally with atherectomy?